Hello, this is Brian Wells. I'm an associate professor in the Department of Biostatistics and Data Science at Wake Forest University School of Medicine, and I'm going to present our project that involved the creation of an automated EHR-based tool for predicting abnormal pulmonary function testing results. I'd like to thank the other team members, Dr. Saha in anesthesiology and pulmonologist Dr. Jill O'Hara. An estimated 15 million people in the United States have undiagnosed COPD, and unfortunately, diagnosis is frequently delayed until patients have already lost 50% of lung function, which is sad given that we have medications now that can improve patient outcomes. Tools for identifying high-risk patients would support targeted screening. The two papers here were mentioned in the most recent GOLD report. These tools are accurate, however, they both require patient and/or physician input. We were looking to create an EHR-based tool that could be run passively on existing data in an asynchronous fashion, and would be easy to implement. So for this project, we used logistic regression. We limited the data to structured data due to ease of use and ease of implementation. You can see a list of some of the several dozen candidate variables that we included in the modeling process. And we measured these variables at the time the patient had their first pulmonary function test. And so we said, based on what we know about the patients at this moment in time, if they undergo pulmonary function testing, would they show obstruction or not? We split our data into a 70% training data set and a 30% test data set for model validation. We excluded individuals who are over 40 years of age, as well as those who have cystic fibrosis. Here's a list of the final variables in our model, and you can see the change in the concordance index as each of these variables are added until there at the bottom. You can see we reached a C-statistic or concordance index of 0.82. In addition to C-statistic, which is a measure of discrimination and an ability to rank patients according to risk, I think it's always very, very important to consider classification metrics as well as clinical utility. And I think this can be best represented in a hypothetical scenario that I'll describe here. And this is a very simple calculation based on the current CMS RVU rate for doing pulmonary function testing. What we hypothesized, if someone gave us $50,000 and said go and find as many cases of COPD as you can in our health system, what's the most efficient way to spend that money? In this scenario, $50,000 would buy you 1,058 PFT tests. If we used our prediction tool to identify those 1,058 patients with the highest probabilities, you could see there we would identify 722 patients as opposed to only 475 patients if you screened the oldest smokers in our system. The nice thing about using logistic regression is we have a mathematical calculation that can be easily implemented into the EHR or run outside the electronic health record. We created a SQL query that can extract data from our electronic health record database and run automated calculations on patients. Part of our project involved holding a stakeholder meeting to determine potential uses for this tool. We held this at the end of June with our medical director of respiratory health, an individual from Data Governments, and the medical director of analytics at Atrium. And the biggest feedback we got was that our model needs to be validated prospectively in a population that was not already selected for PFT testing. So in order to do that, we've estimated we would need a sample size of about 500 patients, and we're looking at identifying funding that would allow us to do this project in primary care. where identified patients would get PFT testing at the same time while respiratory tech administered surveys in order to calculate risk according to those previously mentioned models so that we can do a head-to-head comparison. And then the question will be, assuming the tool continues to be accurate in prospective validation, is what to do with it. We have run a previous project where an EHR-based tool for identifying patients at high risk for diabetes were contacted directly through text messaging to go straight for treatment. We will continue to talk to folks to see what the best route is for this project, but I'm aware that many CDS tools that target physicians have had little impact in the past, and so trying to come up with an efficient way to take these predicted probabilities and to be able to do efficient targeted screening. So thanks for taking the time to listen to our project, and I look forward to the summit. Thank you.